everybody. After lunch, we are having a session on imaging, and we'll make all efforts that we'll make it interesting and keep the sleep away. So please don't nap. And we are going to discuss about the newest imaging modality, that is OCT angiography. It's a modality which is gaining popularity. Newer machines are coming. We have got 4 machines. The machines are costly, and we are also learning about the newer imaging modalities, how to interpret it, how to read it. So we'll keep this session at basic, where we'll learn how to read the reports and what to interpret. So our first speaker is Dr. Ritesh Narula. He works in LVPI as a senior consultant, and because he has access to all the machines available in the market, so he'll be giving overview which machine you have to choose and which machine will give the best results and what are the economics of these machines. So Dr. Ritesh Narula, please.
Very good afternoon to all of you. Thank you, Dr. AVNINDRA, for inviting me to this interesting IC. OCT angiography, as he rightly said, is something which is the new baby on the block, which everybody is now looking at, wants to use, want to acquire. And so it's important to understand what is our available options, and economics, I'll touch upon it. I'll give you the economics of it, and then you can decide how much economics suits you or doesn't suit you. I am going to be touching upon these machines not in a very theoretical manner. I'll try and just give you a brief overview of how these machines differ from each other, and then you can take your best call as to what suits your practice. OCT is a very important imaging innovation in ophthalmology in recent years. It has grown in leaps and bounds. A lot of uh, pre-treatment protocols are now based on OCT angiography. Slowly and steadily, it is trying to replace other forms of imaging. Uh, it's kind of becoming a replacement to dye injected angiography in quite a few scenarios. And as the time has gone, the OCT angiography has grown in resolution, the field of scan, the predictability, repeatability in terms of reducing the number of artifacts, all those have improved. So the world of OCT angiography is expanding from a small, very kind of magnified view to a larger kind of a view that you can get when you're looking at OCT angiography. And this has happened because of technological advancements, and there's a wide area of machines which are now available in market which you can choose from, select from. But to do that, you need to understand a few basic differences between these machines. I'll be predominantly touching upon 4 machines which I have personal experience of using, and try and show you the difference, and most of these are based on similar kind of platforms. So to understand the difference in machines, first you also need to understand what is the principle of OCT angiography. So to understand the normal or a pathological vasculature, what is done is serial OCT B scans are taken at each particular retinal point, and because of the blood which is moving within the blood vessels, the signal varies when the scans are repeated at the same point. This is basically reflections which are coming from erythrocytes within the blood. This reflection change is converted to what is called as a numerical value as a voxel, which is volume plus pixel as a combined term used as voxel, and which is then mapped out or plotted out for you to see. This all is happening within the machine. The machine uses either the reflectance or the change in phase to understand the difference which is happening between the reflected scan, and then it is projected on to you as a 3-dimensional functional OCT image and with the vessel seen on it. So these are the 4 or 5 commonly available machines that are available, which I'm going to be talking about. So the first difference that one has to look at is what kind of a OCT machine that we are looking at. So the RTView XR Avante, the Spectralis and the Cirrus are spectral domain OCTs, while Plex Elite 9000 and Triton is a swept source OCT. So as we know, swept source OCT works on a more depth enhancement or more deeper penetration. You get to enhance your depth evaluation is a lot more. So that's one thing wherein they differ from the platform that is being used for OCT angio. The scan speed between these machines differs from 70,000 at RTView Avante to about 1 lakh for Plex Elite and Triton Topcon. The difference here is the faster the scans are, the lesser chances would be for artifacts to come in. Then is the wavelength. As I said, SWEP shows longer wavelength. They have more deeper penetration for you to see. Each of them have their own mechanism of tracking the eye movement and trying to reduce the motion artifacts, and each of them kind of works fine. A lot of them have now got incorporated to kind of reduce the projection artifacts and motion artifacts. Another important difference that you need to see is the axial resolution between these machines. So an Avante will have an axial resolution of about 5 microns to 3.9 by Spectralis and to about 1.95 by a Plex Elite or a 2 for the Triton machine. So grossly in terms of opticals, this is where they differ from. What they also differ from, which I'll talk about in the next slide, is the algorithm that they use to measure those voxels or what we were talking about previously in the scan, and to kind of interpret those change in reflectance. Next, they also differ in terms of the area that you can scan with these different machines. So this, what you are seeing, are 4 different scans of 4 different kind of area that can be mapped out. The first one is a 6 by 6 mm scan. So the AngioView, RTView, Avante, which generally has a 3 by 3 or a 6 by 6 scan. The latest version also has an 8 by 8 scan for an Avante. From there, this what you see is an 8 by 8 scan. This is from Cirrus 5000. It's an 8 by 8 scan. Cirrus also gives you an advantage of montaging this 8 by 8 scan. So this is a montage of a Cirrus 8 by 8. And coming on to Plex Elite, which gives you a 12 by 12 scan, which you can further montage to give you a really almost beyond equator kind of a OCT angiography image. So this is how you can try and differentiate between the 4 machines. So you differentiate them in terms of their artifacts, their resolution, their area that they allow you to scan. So coming to the algorithms that we were talking about to evaluate these OCT angios, so there are 3 basic algorithms which are there. SSADA, which is the split spectrum amplitude decorrelation angiography, OMAG or the optical microangiography, and OCTARA, which is OCT angiography ratio analysis. We don't need to go too much into detail of these mathematics. You have to remember SSADA is one which is with OptiView, RTView. The OMAG is the one with Cirrus, and the OCTARA is the one which is with Triton. So the difference is when you compare these different algorithms, the OMAG as a method of utilizing this OCT science provides the best visual result for retinal microvessel networks. So OMAG, that means the Cirrus and the Plex Elite would give you the best retinal blood flow in terms of resolutions. SSADA, that is the one with OptiView, gives you the fastest of the scans with reduced number of repeat, because it has the least number of repeated B scans. So SSADA is able to give you a very fast kind of an OCT angiography. The OCTARA, which is developed by Topcon, it has a small issue that though it is a very high resolution scan, wherein the areas, it is best to develop the microvessels in a deeper tissue in terms of choroid. In presence of intact RP, all algorithms almost work well in looking at choroidal blood flow detection in terms of quantitative analysis, wherein there are a lot of high reflectance materials like hard exudates and all present. OMAC can over diagnose vasculatures. So these are small subtle differences between the machines that you have to keep in mind. In terms of quantitative analysis, all of them are working almost the same. Also, you have to understand that these machines are not exactly replicable. For a scan from one is not exactly replicable to another. Why? If you just look at the segmentation from these different machines, you'll realize these lines are not exactly at the same level. So they have different algorithms within them, how they segment different layers of OCT. So an angioplex would segment it in a different way, and there will be subtle differences in what they call as RP and what they call as inner retina and what they call as outer retina. So these subtle differences are there between all the 4 machines. So one should very carefully interpret scans from one machine onto another machine. Now, specifically coming on to what does each of these machines offer you extra compared to what I have already talked about, the RTV Avante has something called as inbuilt angioanalytic software, wherein it gives you certain calculations which are inbuilt in terms of the vascular density, the foveal avascular zone, which can directly be seen on the machine printout directly here that you can see them. Also, you can calculate manually things like flow area and CNV area on Avanti. The Zeiss platform, that is Cirrus 5000 or Plex Elite 9000, it has an inbuilt montaging program which increases the field of view to quite a big extent. And it also in this montaging view, and though you can't segment each of those layers separately, but montaging is very beautiful when you're looking at vascular diseases of the eye, especially diabetic retinopathy and vein occlusions. So this is our images from the Cirrus 5000 6x6 mm high resolution. These are octas where you can very beautifully pick up the networks of 6x6 on Cirrus 5000. And this is a BR view patient showing this 8x8, and then you can montage it to get an 8x8 montage, or a Plex Elite, which allows you to see this new vascularization going all the way beyond the equator also. Now, coming to Triton, Triton gives you an advantage that it also adds color fundus imaging, red free and autofluorescence, and in some models fluorescent angiography along with the SSOCTA device. And it's a swept source. So swept source means a deeper penetration. You tend to evaluate the choroidal vasculature a little better, choroidal thickness a little better with the SSOCTA system. So these are images from Triton, wherein again you can see. So in terms of network resolution, you are able to pick up your networks within the choroid very nicely in the outer retinal layer as seen here. It also has a bit of angioanalytic software attached to it, like the RT view. The Heidelberg has a very small area which it is giving. It doesn't have that big and montaging or an area that it gives you, but it is a beautiful multimodal kind of a platform wherein you can see, simultaneously do FFA, ICG, and OCTA, overlay them over each other, and can compare what you are seeing on OCTA with an FFA at a real time level, which can only be done with the Heidelberg system, not with any other system. Last, the cost, I have listed it up on, these are the approximate costs which are there for each of these machines. Now you have to understand what you require in your practice, how much can you afford, and then take a call what suits best for you, keeping these costs in mind. Thank you.
Which machine you are using at your center?
Sorry.
Which machine are you using in your center?
So,
And which, like you are using multiple platforms.
yes.
So which platform you see the best in diagnosing
So
this?
I'll tell you, in terms of when I'm looking at a diabetic or a vascular disease, my intent is to look at the montage, and I prefer using the Zeiss Plex Elite or the Cirrus 6000, 5000, which gives me a large montage, allows me to go wider in my field of view. I prefer using that. But when I'm looking at depth of the disease, when I'm looking at choroidal neovascular networks, my preferred choice is using the TopCon system. TopCon gives me a beautiful swept source image from the deeper tissues. It's a real workhorse. It has a very, I mean, honestly putting, very low breakdown. It is very useful in terms of getting a fundus photo along with the TopCon OCT angio. And so that's my preferred choice when I'm looking at CNV networks. Though Cirrus also gives you a nice CNV network, but Cirrus, compared to Cirrus, the TopCon just gives you that extra when when you're talking in terms of depth.
And
Choroidal networks.
how are the fast tracking systems and motion artifacts
Now, most of these
reducing?
machines have their own tracking system, all the near-term model. So the amount of motion artifacts, unless and until the patient is not at all fixating and is not able to just hold its eye, the minor, that saccade-based motion artifacts, most of them have a kind of a way to tackle it. Also now they have, especially the Heidelberg and the Zeiss, have something called as projection removal kind of a platform also, where you can actually remove the projection artifacts. So that also works. So artifacts have gone down. I won't say they're completely gone down. Depends on patient's fixation also. And the more the retina is compacted, the more the number of artifacts tend to increase.
And which machine, if somebody has to buy in the audience to choose for a machine, so which machine and what should he look into the machine to buy that machine?
So look at what do you need this machine. Do you want a standalone machine where you are not interested to have an FFA, ICG, nothing of that sort? You don't want a fundus camera. So then you can look at a purely just an OCT angio machine like an RTView, which is little cheaper, gives you a decent and a fast scan, decent OCT angio and a fast scan. But if you're looking at something which can act for you both as a camera plus an OCT angio, or you're looking for something which acts for you as a angio plus.
And I want a definitive answer. You are giving
No, no,
pros
I'm
and
telling you
cons.
what you need in your practice. You have to decide if you want to buy two separate machines, a camera separate from an OCT angio, your choice. If you're looking at a standalone OCTA,
If you want to buy, what machine you will buy?
so if I have to buy, my first choice would be to go for a Cirrus 6000, honestly, because it's the best mix of giving me both the depth as well as the field. It may not have the 12.12 montage, but it has a good 8 by 8 montage, which is good
It has
enough for.
got 12 into 12 scans also.
Yeah, it has a 12 into 12 single scans, but it doesn't have the montaging
Montage.
feature on that. But it has good 8 by 8 montage. It also has a decent depth. Also, it allows me to do a lot of image analysis also.
I just also like to, raise the flag of you mentioned. I think that's very right. That if you are thinking of diabetic retinopathy and things like that, perhaps the size systems are very good at giving you a periphery and looking at the vasculature in the retina. But if you want to go below the RP, my go-to is usually the spectralis because I just like SLO based systems, and it also allows me because in a lot of the cases of macular degeneration, we know in India it's about 30% is PCB. So to be able to do FFA ICG and juxtapose that against all this, just
So
a thought.
Spectralis works beautifully with depth again as
Yeah.
either Spectralis or Topcon, which allows you to go more deeper. With us, it is we keep our Spectralis more for FAICG. We don't let it being used for OCT angio that much. So, but yeah. So as I said, it depends on
And
what you're
do you
using.
have Heidelberg system also at your place?
Yeah, we have. As I said, Heidelberg OCT angio we are not using that much because that machine mainly runs for doing our FAICGs. So
Puneet, will you like to add on to something about Heidelberg? How? But it has only eight, maximum of 8 into 8 scans. So what machine are you using, Dr. Rajesh?
So I have actually worked with the RTView, the Zeiss Spectralis 2, and also the Plex Elite. I think I agree with him saying that there's no clear answer as to which machine works best. It works best depending on your practice. If you already have a good Spectralis machine and a fundus camera, it wouldn't make sense to buy something that's got everything on because that adds to the cost. That's one factor. None of these machines are really cheap. And at this point in time, I think for retina, yes, I'm a glaucoma specialist, so there's much more value in retina to have this as a device, but it has still not become a definitive sort of required tool in anyone's practice at this point in time.
With this, we'll move to the next talk, that is OCT interpretations and artifacts. OCTA was first introduced in 2014. It's a new armamentarium in retinal imaging, fast and non-invasive, dye-free angiography with faster acquisition. Prior to OCTA, FA and ICG were the mainstay and the modalities for retinovascular visualization. FA and ICG generated two-dimensional in-fast view of the retinal vasculature. OCTA allows individual visualization of retinal capillary plexus. OCTA in vivo visualization of the retinal microvascular in a depth resolution fashion. Uh, if you look at the OCT image, it gives a cross-sectional image. Like if you cut a cake like this, you will see multiple layers of the cake. Similarly, OCT B scan gives a cross-sectional image of the retina. But if you go on to the Octa images, this gives you an in-fast image. And like you cut the cake in a horizontal fashion, then you get multiple slices. And this is what an Octa does. Important thing in Octa is segmentation. So you see this line moving here, this line, and if you see this line moves, and if it when it comes to the level of RP, you can see the lesion. So it's very important whenever you are interpreting an octa image, you have to look these lines where they are placed and in concurrence with your retinal pathology. Because if these lines are made up and below, then your diagnosis with OCTA will go wrong. Uh, this is a small video showing how OCT angio is done. And since I have a Zeiss Angioplex 6000, so it's a non-invasive dye-free with single scan. Motion of red blood cells is detected by sequential OCTs. Based on the properties of light reflected from red blood cells, motion is detected and vessels with blood flow is detected. It has a fast track system, so motion artifacts are decreased in this system. And patient blinks, it stops, and once the patient starts fixing again, it again starts tracking the eye. It is powered by OMAG algorithms, which takes care of the amplitude and phase from the OCT in single data. You can see multiple layers. This is a superficial layer, this is the deep retina, and this is the avascular layer, and you have the choroid and the choriocapillary layers. There is a color coding. Red is for the superficial, deep retina is green, and avascular retina is blue. So if you see a compact image, there are preset modalities here. You can see retina, superficial layer, deep layer. These are angioplex pictures, and these are structural or deep layer, and then you have an B scan pictures. And these red dots, what we see is an flow overlay. So we have two machines. One is spectral domain versus swept source OCT, and as Ritesh has already mentioned, uh, swept source is faster and covers a greater scanning area. Choroid can be scanned easily in swept source, but resolution is higher in spectral domain OCT based OCTA systems. The problem with swept source OCT is the cost is double. Whenever you are interpreting an octa image, there are three images here. One is an NFOS image. This we call as an angiographic image. Then you have an structural NFOS intensity image for the selected slab. And you have an corresponding B scan image. So whenever you are interpreting an octa image, all the three images has to be taken into consideration before interpreting any disease pathology. Uh, the area of a scan is determined. Then look at the NFAS image. Look at the segmentation line. These red lines are segmentation line. Look at the B scan with flow overlay. This red dots and green dots, what you are seeing, shows the vascular flow in the particular area in the vessels. And then you look at the NFAS intensity image, or what we call as in structural images. The first step is to interpret to ensure which area of the retina you want to scan. Depending on the type of lesion, you can choose the block. If it is a CNV, you can choose a 3 into 3 millimeters, or a larger macular lesion, 6 into 6 millimeters. Diabetics, you can, because you need more area for capillary non-perfusion, you can either go in for 8 into 8 montage or 12 into 12 slab. This is what you see. This is 6 into 6 slab. This is good for macular area where you want to see a magnified image. If you want to look at the peripheral image, then you have to go for an 8 into 8 montage. And since montage, what happens, you have to take 5 pictures at a time. So the acquisition time increases, so you can do 12 into 2 a 12 scan, which will give area similar to 8 into 8 montage. And if you have like Plixelite 12 into 12 montage, then you can get 16 into 16 scan, which covers till the equator. There are various preset features shown in the report here, which shows a superficial layer, deep layer, avascular zone, choriocapillaries, and each of the layers I'll be discussing here. The superficial retinal slab extends from internal limiting membrane, ganglion cell layer, and inner plexiform layer. Uh, Captures the superficial capillary plexus, part of the radial peripapillary and capillary plexus. This slab is important in retinal vascular disease where dropout or malformation of microvascular circulation is seen. Like in this patient, whenever you want to see a foveal avascular zone, then look at the superficial slab. You can see a regular foveal avascular zone. And then if you see in this patient, you will see areas of capillary dropout and macular ischemia. Deep retinal slabs extends from inner nuclear layer out to intermediate deep capillary plexus. OCTA is the only available tool which can detect deep retinal slabs or deep capillary plexus. Deep capillary plexus cannot be taken or distinguished on fluorescein angiographic picture. And this is you can see this slab here. If you click on this, you will get deep capillary plexus, and the line segmentation lines comes below the in the middle of the retina. The avascular zone extends from outer plexiform layer, the outer nuclear layer, and this slab is avascular in healthy individuals. Any vasculature in this slab signifies pathology, and these pathologies can be CNVMs or neovascular abnormality. Coming to the choriocapillary slab, this is the choriocapillary slab is defined as 20 microns below the retinal pigment epithelium. Much like the avascular slab, the choriocapillary slab should be evaluated in AMD and other pathologies associated with MNB formation. Choriocapillary slab, you won't see the vessel, you will see voxels in this. And in this patient, what you can see here is a CNV, uh, and there is also one slab called sub RP slab. If you see the sub RP slab here, you can see it automatically takes care of the motion artifacts. So it automatically follows the line of the pigment epithelial detachment. And if you see here in sub RP slab, I can detect an PCV or an polyp here uh, in an pigment epithelial detachment. ORCC slab is a combination of outer retinal and choriocapillary slab. It was first described by Rosenfield. This slab spans from the outer plexiform layer, the outer nuclear layer, and the choriocapillaries, and is best in case of type 1, type 2, and type 3 CNV. And this is one of the patient of juxtafoveal telangiectasia. You can see an atrophy here with the simultaneous CNV. Another patient undergone, if you see this slab, you can see a CNV and SRF here. So all three images has to be interpreted to come to an conclusion. Choroidal slab displays a 50 micron slice posterior to the choriocapillaries. Differences in wavelength and light source lead to variable detection of choroidal vasculature. This is one of the patient. You can see this segmentation line. This is in the choroid, and you can see a large dilated vessels, which suggests that this patient is of pachychoroid disease. Segmentation line, we have talked before also. Preset slabs in OCTA devices are generated by automated segmentation. And because of many times, because of this pigment epithelial detachments, you are not able to detect where the lesion is. So you can see here, if you see, this is, we are scanning the superficial, but I have done a manual segmentation. I have brought down, you have to click here and roll your mouse, and this segmentation line comes here. And if you see in this patient, you can see an BVNs, which is suggestive that this is a patient of a polypoidal choroidal vasculopathy. Within edge of the PED, you can see an branching vascular network. Uh, B-scan overlay is basically, if you see this red dots and yellow dots, this shows what is the flow of the blood at a particular area. So whenever you have to see whether it's an artifact or actually you have to, what is the flow into it, what you have to do, you have to bring this line in the area where the lesion is. Then once you bring this line, you will get a simultaneous B scan pictures, and these red dots will show that there is an high perfusion in this area, suggestive these are not artifacts. Actually, these are abnormal vessels which you have to treat over a period of time. In many high then the third image what you see here is an structural image, and if you see here, this is a patient of a diabetes, but on OCTA pictures we can see areas of capillary non-perfusion, but we cannot see an NVD. But in structural image, what you can see, there is an NVD here and there is a fibrovascular proliferation. Maybe the blood flow is not there, so you are not getting a flow in this area, or you cannot detect an abnormal vessel on the disc. Meaning thereby, one image in OCTA will not give you a definitive diagnosis. You have to correlate all these three images to come to an final conclusion. Uh, Okta also helps us to compare picture. This is one patient. You can see the signal strength is good and almost the same. Uh, we have given anti-VEGF. This patient was QSIN for a period of 4 to 6 months. When came, there is an enlargement of an CNV or a progression of a CNV. This indicates yes, you have to re-inject in this patient. Coming to the artifacts, there are various artifacts: signal strength, motion artifact, projection artifacts, and segmentation artifacts. Uh, Whenever you are interpreting an OCTA image, you always look at the signal strength which is given here, and you can see there is a loss of capillary perfusion in this area, and the B scan images are not clear. This patient had an posterior subcapsular cataract, and because of this subcapsular cataract, the acquisition is not good. So this is very important to prevent any kind of a misdiagnosis, because if you see this picture, you will see say ki there is an enlargement of FAZ, but actually these pictures, these are artifact because of the posterior subcapsular cataract. Uh, Motion artifact, if you see this lines here on the structural images, this tells us that the patient fixation was not good whenever when the image acquisition was taking. And motion artifacts are taken care by two softwares. One is an eye tracking device and software motion correction devices. And because of this tracking, most of the machines now have a tracking device, so motion artifacts are becoming lesser and lesser. uh, the moment you do a smaller slab, then the motion artifacts are less. Larger slabs requires more time and more time for fixation. So if you go for a 12 into 12 slab like what you see here, the chances of getting motion artifacts are higher as compared to taking a smaller slab. uh, Shadowing, this is one of the patient you can see is this patient has an pre-retinal hemorrhage plus and subretinal hemorrhage. And if you see this picture, because of the pre-retinal hemorrhage, there is an shadowing to the underlying tissue. Uh, if you see this here, this lesion here, the vessels are dilated and you can see the flow is pretty high. So this is one of the patient we could diagnose on OCTA as a case of retinal artery macroaneurysm. Uh, Projection artifacts, you can take care of the projection artifacts by manual segmentation. Like in this patient, I did a manual segmentation and you can see a notch PD, which is suggestive of an fibrovascular disease process. And at the edge of the notch PD, you can see a BVN. And we do an sub RP scan where the motion projection artifacts are taken care. And in this patient, you can see an polyp here, one single polyp. And this is one of the rare cases where I have been able to diagnose a polyp in cases of NPCV. There are projection artifact removal softwares which are available in the machine. I won't go into the detail because of the time constraints. Slab subtraction, voxel by voxel, and three-dimensional power algorithms are available to diagnose this disease. Projection, when interpreting octa images, the easiest way is to detect projection artifact is to compare in fast flow with the corresponding B scan. Like what I have shown here, the flow is good here. That means this is there is no artifact in this image. Segmentation artifacts we have already discussed. So to conclude, all three images enforce octa images with structural OCT with B-scan. Flow overlay should be assessed for the correct diagnosis. In doubt, always sit on the machine for correct segmentation and B-scan overlays. It is evolving technology with lot of things to learn. Thank you very much for your kind attention. Any questions from the audience?
Thank you, Dr. Avnind. Just one small point, no question. One of the scans that I use very often is the RP fit scan, especially in presence of pigment epithelial detachment. It allows you to take the second line which goes above the PED, and it allows you to pick up the network without the issues of projection coming in between. So that's just one.
That's again something I think with Zeiss Systems brought in Dr. Rosenfeld specifically.
Yes, yes.
Yeah.
Gupta. Puneet Gupta has a practice in Ghaziabad, and as a solo practitioner, I can say he is the he has the latest generation machines. Only surgeon in northern India to do an endoscopic surgery. Very well versed and a person who will always stimulate you to learn, and learn. Dr. Puneet Gupta.
Thank you, Avnindra, for kind introduction. Thank you for including me in this interesting instruction course. Good afternoon, everybody. I'll be talking about OCT angiography in relation to age-related macular degeneration. I'll be talking about a little bit about the background of OCT angiography in technology in relation to AMD, utility of OCT angiography in diagnosis and management of CNVM in the OCT, and also diagnosis of CNVM in non-AMD because they are the differential diagnosis. In my opinion, AMD is one retinal disorder where the potential of OCT technology is best utilized and gives practical clinical information which is translated into clinical use. So this has already been discussed by Dr. Avninder in detail, where various NFAS maps of vascular patterns of different layers are created and represented on the screen. And along with the NFAS, in addition to NFAS, slab-based NFAS angiogram, OCT data can also be viewed on cross-sectional flow cross-sections, and the flow data is superimposed on that cross-section images. This is very important to differentiate the lesion. The yellow color here demonstrate the flow in various layers. These are the pictures of Heidelberg machine. This is the area where we focus in age-related macular degeneration patient. This is avascular complex, and this is choriocapillaris, and this is choroidal area. So this is the area where the most of the activity in age-related macular degeneration occurs. To generate an image on OCT, there has to be a minimal amount of flow within the vessels to create a differential image. If there is no flow, the OCT angiography will not create an image, and this is very important in detection of choroidal neovascular membrane. OCT has been demonstrated to have high specificity and sensitivity in detection of choroidal neovascular membrane in various layers. All kinds of choroidal neovascular membranes can be very effectively detected on OCT angiography, whether it is type 1, 2, or 3. In neovascular AMD, because the retinal architecture is very much disturbed, it is the automatic segmentation of the layers is not very reliable. So you have to use the custom segmentation slab to locate the flow within the lesion. This is the custom slab which you move over the lesion to detect the slab in the ANFAS image. So by reviewing both ANFAS and cross-sectional OCT together, it increases the specificity and sensitivity of detection of choroidal neovascular membrane if you compare it to the ANFAS image alone. Segmentation should be correct to locate the choroidal neovascular. If you see in this image, this area, the segmentation line is dipping below towards the choroid. So actually what you are seeing here is not a choroidal neovascular membrane, it is actually the choroidal vessel which is showing the flow here. So the diagnosis of choroidal neovascular membrane in this scan is not correct. So this is type 1 CNVM, where you see the membrane which is below the RPE. This is type 2 CNVM, where you see this membrane which is lying above the RPE. The membranes can be both combined or mixed, where that means there can be type 2 combined with type 1. PCV, the gold standard for detecting PCV is still considered ICG, but since ICG is not available everywhere, OCT angiography and OCT images can also be utilized to detect PCV pathology quite reliably. The flow in the thumb-like PED at the tip of thumb-like PED with a double layer sign, along with it having a branching vascular network, is an indication that there is a possibility of PCV. It is generally difficult to pick on OCTA due to poor flow in the polyps. These polyps that are present in PCV, they do not have good flow. That is why OCT angiography is not a first choice of detecting flow in PCV patients. But if you combine it with cross-sectional images, there are chances that you will be able to detect the features of PCV by which you can make the diagnosis. But still, ICG angiography is the gold standard. In non-exudative CNVM, this is an example of a vascularized drusen, where you can have flow within the drusen, and this can only be detected on OCT angiography. It is missed on fluorescein angiography and OCT. Another scenario of non-exudative choroidal neovascularization is quiescent choroidal neovascularization. That is also found on OCT angiography. The difference between the vascularized drusen and the quiescent neovascularization is that the vascularized drusens grow vertically, whereas the quiescent neovascularization grows horizontally between the layers. Both these situations may develop exudation at a later date. 20 to 80% of the non-exudative CNVMs, they eventually convert to exudative choroidal neovascular membrane, and they need close follow-up, but no treatment is required until they develop exudation. So detection of these non-exudative CNVM, which can only be possible effectively on OCT angiography, is important. Similarly, in patients with whom you are treating, the patients with neovascular AMD, the fellow eye examination is also important. These fellow eyes may have neovascular, these non-exudative membranes which may be missed. In this patient, this is the first image of OCT where there is some atrophic changes, but if you see here carefully, there are some Schrem areas and some activity here. On angiography also, some flow is detected here. And this patient developed the exudation, and the flow is detected on OCT angiography. So this is another interesting patient. This was a 60 years old lady with 6x9 partial vision in both eyes, some drusenite type of changes, drusen changes in the outer retina. And on OCT angiography and OCT, you can see some drusenoid PEDs, but no flow was detected in this patient. This patient developed some hyporeflective spaces, and it looked like a serous detached, some fluid within the retinal layers. And subsequent OCT also, this hyporeflective space increased, and this patient was given anti-VEGF injection, but there was no improvement in vision or fluid. This was the OCT angiography, which showed no choroidal neovascular membrane. Again, the fluorescein OCT angiography was done. That also showed no flow signal, and subsequently also the space increased, but there was no flow at the on OCT angiography. These are some reflection artifacts, but not exactly the flow. So this was actually the adult onset vitelliform dystrophy, where the vitelliform material has absorbed and is giving an appearance of fluid within the retinal layers. There was no CNVM or flow on OCT angiography. This is the other eye picture of the same patient. So OCT angiography is also a reliable tool for confirming the absence of choroidal neovascular membrane in neovascular in retinal disorders. Now, the management of follow-up of these patients, OCT angiography is very helpful. These are the sequential photographs, and if you treat these patients with anti-VEGF injections, these vascular fronts, they get they change in shape and their vascular pattern. The maximum regression of these vascular fronts, the capillaries and the branching network, they occur at 2 weeks after the treatment. The reproliferation and reopening of the previously closed choroidal neovascular membrane is again noted by 4 weeks. So all these features are helpful in managing your patient, how the patient is responding. Though till now we are managing all our choroidal neovascular membrane patients, neovascular AMD patients, by assessing the fluid. We are not using the biomarkers of OCT angiography for managing these patients, but these things will come up as our understanding of OCT angiography develops. Now, these fronts can be active and non-active, or you can say immature or mature. The active fronts, they appear like densely packed nets of C fans and with extensive branching. There will be extensive branching in active lesions. The extensive capillary sprouting and numerous anastomosis can be seen in these active lesions, whereas once the choroidal neovascular membrane gets matured, they become larger in diameter, filamentous vessels with lesser branching and lower capillary sprouting. And this maturity develops after almost about 6 months of anti-VEGF treatment. I'll skip this dry AMD slides because I'm already. So one important thing I want to convey is, for proper quantification of choroidal neovascular membrane, proper quantification and proper detection of choroidal neovascular membrane, segmentation should be correct. If your segmentation is not correct, you will not make the correct diagnosis. For that, you have to sit on the machine and diagnose the things yourself. There are limitations. Dr. AVNINDRA has already explained those various artifacts and limitations, but still, OCT angiography has high diagnostic value in detecting the presence or absence of choroidal neovascular membrane, and is a useful and dependable tool in management of neovascular AMD. Thank you.
Thank you, Puneet. I'd like to invite Dr. Lalit Verma, our president, to give his talk. He'll be talking, will OCTA replace fluorescein angiography? And the same question I'll ask Puneet also, whether he is using fluorescein angiography in cases of choroidal neovascular membrane or macular disease.
For macular degeneration, I think if you have OCT angiography, there is not much role of doing fluorescein angiography. You can delineate choroidal neovascular membranes much more effectively than fluorescein angiography.
Especially in neovascular AMD, was only for identifying classic CNVMs for doing PDT. Now that is totally out of the window, and once anti-VEGF therapy has come in, there's no real need to distinguish the types. The only real area is to distinguish between neovascular AMD and perhaps an polypoidal choroidal vasculopathy, where you really need FFA with ICG. So that is one. Also, in cases where you suspect that there may be a RAP lesion, and so you would like to see, that early angiogram the emanation from the retinal circulation. So these are the indications, but as Dr. Puneet said, by and large, for neovascular AMD, you really don't need fluorescein angiography as much as
What from
Dr. Rajesh.
Ajay and Ritesh and Rajesh, whether you need angiography in case of
Sir, FFA for AMD is, I've stopped using. I don't use FFA. I think OCTA is more than sufficient and better than FA, and it's quick and it's more reliable.
Yeah, I just had a question. If the AMD patients, advanced AMD, who have fovea involving diseases, the fixation is a problem in acquiring the scans many a times. So many segmentation artifacts and motion artifacts do happen, especially if the patient also diabetic patients who have significant.
I'm happy some man is there to defend this also.
So any tips to improve the image quality?
if there is a there's a poor fixation in one of the eye, you can ask you can give an external fixation to the other eye and then take the scans.
Then
The only thing is this disease do progress bilateral symmetrically. So in the other eye also many a times.
Yeah, some cases it's difficult. I totally agree with you. Sir, please.
thank you, Vrinder. I think deliberately he has given this topic to me because all these are young people. They've recently acquired OCTA machines and they have a lot of experience. And I, being all gray hairs, am more, using FA machine and gradually learning OCTA. Thanks, Vrinder, for designing this session so well. You see, today is an era of multimodal imaging. We keep talking of all these modalities which are there. And OCTA is now not a new baby, but recent addition to all this. What I am going to convince you is that even in this era of, this 10 multimodal modalities listed here, FA, I think, is still not dead. A lot of people keep saying that they use only OCTA, but I am not one of them that I will use only OCTA for this thing. The only conditions where I have used only OCTA is maybe myopic CNVMs or otherwise. To my thinking, it does not replace fluorescein angiography also. FA is now, we have a wide field, ultra wide field. Even OCTA also is now has, more machines are available for wide field. But still, there are limitations, whereas wide field angiography is now more easily available. Long experience with the FFA, and in a very short span, you get wealth of information about so many diseases. Apart from being cheaper and less artifacts, what was being talked about now only by one of the members here, less motion dependent. Plus, it's a dynamic study. You study the flow. Although OCTA also is dependent on, like Puneet was saying, some flow. If there's no flow, you may not be able to differentiate much. Neovascularization, a lot of times I've been misled actually. I've been misled primarily because there are so many patients who have what we call quiescent CNVM and or we early kind of CNVM, which pose a dilemma. Because if you keep seeing this photograph on the outer level, you see those neovascularization, you're not convinced whether to treat or not, and if you are treating only on the basis of OCTA, you may overtreat such patients. Disadvantages of FA are there that people will shout, OCTA proponents will shout that it's invasive, and even death has been reported. One death has been reported, but believe me, they're so rare, so rare. So here I have tried to make a table here, and red one indicates the plus points of the respective machine. So wider angle FFA is very easily available nowadays. OCTA, the advantage is non-invasive, can be repeated whenever you want, but it requires a lot of learning. You have to sit there on the machine for a very, very long time to keep understanding. And resolution definitely is much, much higher. And big advantage is this NFAS imaging, that all 4 levels can be segmented: superficial, deep, outer retina, and even choroidal. But FFA is known for its dynamicity, plus less of these artifacts. Equipment cost is cheaper, and then decades and decades of experience is there. I will try to list a couple of conditions where FFA has helped me more than OCTA, so that just to impress that FFA still has a role. Especially wider field angiography, if you do, And peripheral lesions, I'm not very comfortable doing OCTA in such conditions. You see, whether it is vasculitis, Eales disease, or peripheral NVE, people may say that you can pick up on indirect angioscopy also, but you see these pictures here tell the story itself. Leakage is another thing which never I'm confident, although flow indices have been described in OCTA, but I'm very comfortable picking up leakage which indicate the activity of the disease. Other thing is about the dynamic property of leakage, which is unique to both FFA and ICG. CNVM, as I said, although Puneet said that you can have idea about whether it is regressed, but I will be very comfortable in case it is leaking there on FA or not, to confirm, like in this patient. Like I said, ultra wide field FFA is a definite reality. Motion artifacts is one thing which is all these artifacts, in fact, which are not there in FA. Media haze is another issue. Like if you have a media haze, then OCTA becomes impossible, whereas you can have some information here. Limited fixation, as was being pointed out, patients may have bilateral ARMD, even external fixation may not work. This is not much of a drawback in angiography. Then other thing is decision making. Decision making is very difficult only on OCTA. In a lot of diseases, especially diseases like if I have to laser a non-center involving DME or a CSR, I would not depend on only OCTA information. And even in things like Coats disease or retinal artery angiomatosis or RAM. So here I would have a frame of FA before I start lasering these patients. Microneedles, people say you can still have an idea on OCTA, but very readily and easily visualization on FA also. Same is true for this. If you have to differentiate between, a lot of people try to confuse between CSR and VKH lesion. I'm very comfortable doing an angiography in these patients and for documentation also. So what I have done is to describe a couple of regions where I'm very comfortable with FA, although I am wary of this fact that OCTA is gradually replacing FFA and ultimately may occupy that position. But as of now, I think FA still is there and is not dead for a lot of these conditions. Thank you very much.
Thank you, sir. A very important point what sir has mentioned is that in OCTA you can see the vessels, but you cannot see the leakage. So only leakage early and late phase you can only determine on fluorescein angiography pictures. Many times we have an laser proliferative diabetic retinopathy, and you do an OCTA, you will see a network of vessel and you will say ki I have to do some laser. But the moment you do a fluorescein angiography, there is no leakage, and actually this patient does not require an addition of laser. CSR patients, uveitis patients, still FA is the gold standard, and OCTA, we cannot replace OCTA with fluorescein angiography. Yes, macular disorders, we are gradually weaning off from fluorescein angiography, but peripheral vascular lesions, OCTA still, fluorescein angiography still is the investigation of the choice. Any comments from Ritesh or Ajay and Doctor?
I agree on a lot of points.
You are free to differ also. It's not necessarily concurrence, but this is what I could pick up where it has helped me.
So for me, OCTA, if I pick up a neovascularization on OCTA at the initial stage, I won't go for an FFA. I'm not talking about under treatment eye. But if I don't pick up on FFA, on OCTA, and my clinical suspicion is high, I rely on FFA to confirm it or not. So finding on OCTA is very strongly positive, but not finding on OCTA does not rule out a disease completely. So
Agreed.
one has to keep that
Yeah.
in mind.
Yes, I agree, because just harking back to the point which I think Dr. Aminda and Ritesh made is sometimes networks may not show. It's all flow dependent. It's virtual. The OCTA network is actually virtual. So if the flow is very slow, you might just miss a network. Also, if the slabbing is not perfect because the RP is highly corrugated, then you may miss it also. So
Yeah.
these are issues which that is where FFA will score.
Also, the fact that I'm not a retina specialist, but we've realized that if you do a fractal analysis instead of the inbuilt SSADAs and the other algorithms you mentioned, you actually tend to get better quantitative analysis. And like you said, since this is not real flow cytometry, you're actually sort of looking at missing points. And if you have low flow and slow flow, you might actually miss those points.
If you have vitreous hemorrhage and if you want to define a lesion in vitreous hemorrhage, you won't get octa images because of the shadowing and poor equation. You have to rely on fluorescein angiography. Thank you, sir. Thank you for your kind words of wisdom, and sparing time for our course. With this, I request Dr. Anand Rajendran. He is the Chief of Vitreoretinal Unit at Arvind Eye Hospital, Chennai. He also has an Zeiss Cirrus 6000, and he'll be talking about diabetic retinopathy.
So it's my pleasure to talk to you about OCT angiography in diabetic retinopathy. I'd like to thank Dr. AVNINDRA for having me here in this IC. So OCT angiography's role in diabetic retinopathy is basically where with OCTA to demonstrate the retinal microvascular changes. So these can be structural or morphological alteration in the form of showing up better microaneurysms, tortuous dilatation, IRMA, NV, collateral shunts, but also demonstrating structural loss in terms of showing up the capillary non-perfusion areas centrally, which is macular ischemia or an enlarged FAZ, or peripherally. And also different indices for looking at structural density, such as perifoveal capillary density, which is fairly popular. So it also shows up different changes in the various stages of diabetic retinopathy. It highlights diabetic macular ischemia, useful in correlating DME with anti-VEGF responses. This is an interesting facet. And also showing up, now that we have wide field OCTA also coming up, peripheral changes of non-perfusion and equating it with the relevant DR stage. Also looking at, very excitingly, evolution or regression of IRMA and NV, and we'll look at all this in a bit. So angiographies, we've talked about this. FEZ corresponds of the fluorescein angiography fairly well with the superficial vascular plexus of the OCTA. But where OCTA scores is, this is the only place where you can see deep vascular plexus. So that's important. And OCTA-FAS, now looking at early changes and stages of DR. So early citers of ischemia on OCTA, you can see, if you look very carefully, disruption in the FAZ on the S superficial capillary plexus. In the deep capillary plexus, as and when you find focal microaneurysms, you will find them, interestingly, to correspond more often than not with CNP areas in the choriocapillaries layer below that. Kim et al. Found increased FAZ dysmorphia, diabetic macular ischemia progressing with progression in the stages, as you can see here. And this allows for quantification, and Alam quantified OCTA OCT analysis and helped compute-aided identification and staging of DR. So looking at OCTA-FAS and diabetic macular edema, and as I said, prognosticative anti-VEGF response. So there have been different studies, and the jury is split. Lee and Atala found that increase in diabetic macular edema corresponded well with the FAZ area increase, which Tarasoli and Han did not find in their studies. Looking at an interesting study by Lee et al., where they looked at OCT angiography and of DME and its association with anti-VEGF treatment response. They looked at 51 poor responders and 32 good responders, and they found, interestingly, this is important, significant damage to the deep capillary plexus, not superficial capillary plexus. And they also said that the marker for poor response would be deep capillary plexus loss and corresponding outer plexiform layer disruption. So this is where OCTA is important, because as I've just said, OCTA is the only one which shows up pathology of deep capillary plexus, not your FA. So you see here a good responder, an example with lesser distortion of the deep capillary plexus and more microaneurysm being shown on DCP than the fluorescein angiography. Similarly, in a poor responder, there was greater distortion of DCP, and again more microaneurysms on DCP than FFA. Now we, after we looked back at a few of our cases, and we looked at cases with good response to anti-VEGF injections. You can see from baseline to 3 months post-injection, fairly good regression. And we found that there wasn't too much of a difference in the superficial capillary plexus. But in the deep capillary plexus, there was definite dysmorphia, and you found that it improved fairly well with treatment in the good responders.
Now we look at a case of a poor responder where there was hardly any improvement. In fact, there was worsening. So you see that in the superficial capillary plexus, not too much of a change, but in the deep capillary plexus, you find significant increase in the dysmorphia. And 1 month post injection, you can actually find that as it's becoming worse on the DME, the DCP FAZ is also increasing. Now, looking at OCTA-FAZ and diabetic macular ischemia, Rosen et al. Showed this in this index which I was talking about, perfused capillary density. So in controls, you can see the red area on the far right panel, which is the capillary density map, that increases in diabetics without diabetic retinopathy. So perhaps in this little twilight zone, there is an increased metabolic push to increase the vascularity because the retina sensing changes. But as it moves from into organic pathology, from no DR to NPDR to PDR, that perfused capillary density is now dropping off slowly. So you can see that red is going and becoming yellow. So Bradley et al. From the Moorfields group, they looked at 24 patients with diabetic macular ischemia and they evaluated this using OCTA. And they clinically defined it as an enlargement of the foveal avascular zone and paramacular areas of non-perfusion. And they compared FFA versus OCTA, the three SCP, DCP, and choriocapillaris. They brought out a novel DMI grading system and looked at it for reliability and consistency. And this is how they graded it. The FFA and the SCP, as I mentioned, these two correlate. They had different grades: absent, questionable, mild, moderate, severe, ungradable. So mild, moderate, severe was based on the FAZ outline description, and mild, moderate, severe is less than or more than half disruption of the original circumference or complete in severe. The DCP, they split it into a 4-quadrant grid. They did the same for the choriocapillaris also. And again, there is absent, questionable, mild, moderate, or severe, ungradable. So mild moderate was FAZ disruption with less than equal to 2 quadrants, and severe was when it was more than 2 quadrants. And it was just a plus or minus response with the choriocapillaris, loss of speckled hyperreflectivity, homogeneity, dark defects if it is present. Then you said macular ischemia was there at the choroidal level. So this is just an example to show what they mean. So this is FFA, which showed diabetic macular ischemia less than half of the FAZ. OCTA SCP correspondingly had the same DMI less than half FAZ. So based on these two, there was mild moderate ischemia in the superficial layers. The DCP showed fast disruption. In the subsequent slide, I'll show you how they graded it. OCTA capillary there were dark defects, so they concluded there was ischemia at the choroidal level. So in the DCP, you find there's 2-quadrant FAZ disruption, and according to their classification, this qualifies for mild to moderate DMI at the DCP level. And you see choriocapillary is also the 4-quadrant, so the DMI is positive because choriocapillary dark defects are positive. So the key findings was the degree of diabetic macular ischemia can be reliably assessed by OCTA, SCP, and more objectively than FFA. And there was moderate agreement between DMI gradient results for OCTA of SCP and FFA. And OCTA DMI assessment, there was much better substantial intergrader agreement than it was with FFA. So the different readers, there was greater agreement between them for OCTA. And OCTA DMI grades correlated very well with the OCTA parafoveal indices also. Now comparing DMI with peripheral capillary non-perfusion. This is a question which often comes up in conferences. So here Handel et al. Showed that OCTA FAZ dysmorphia and diabetic macular ischemia correlated very well with increasing peripheral capillary non-perfusion. Now looking at wide field OCTA and what implications it has, especially for PDR. So one of the advantages of wide field OCTA is combines both structure and flow information, identifies extent of retinal non-perfusion, detects onset and severity of macular edema, intraretinal microvascular abnormalities or IRMAs, as well as retinal neovascularization. It's useful to determine when to treat and for following response to treatment, and it lends itself very well for futuristic novel staging criteria for diabetic retinopathy. It's an example of a 41-year-old male who has diabetic macular retinal thinning, as you can see here, and this corresponds fairly well to an area of capillary non-perfusion on the 3x3. When you move on to a 6x6, you see that it corresponds well to the retinal thinning out there on the RPE, and when you move to 12x12, you see that it also correlates to different multiple areas of CNP in the periphery. Now another patient with DM, you see on that small little macular thickness map here, this extent of the macular edema. And of course, you see there's a lot of macular edema there. Now, when you, with the wide field, when you look at a 1515 retinal thickness map montage, you see that area is actually much larger than what your original capture was. So this corresponds to the macular edema and this peripheral capillary non-perfusion in the distance. And when we move that slab up, so the previous one was superficial slab, and I think I skipped pages. Yeah, right. So now in this patient, there's a this is a 1515 retinal thickness montage, and you see that thickness out there, and this corresponds with non-perfusion out there. And when you move to that VRI interface, so in this superficial flow montage, you see the line, the slab is right here. So this is superficial. You're getting all the superficial capillaries. You're seeing the non-perfusion area. That's fine. But when you bump that slab up to the VR interface, vitreoretinal interface, which is here, you see in isolation that elevated neovascular tuft. And this is beautiful in picking up early neovascularization. You see one there, and this corresponds beautifully on the VR interface to this bump which is rising up. Similarly, on the right side, you find another area of neovascularization, and that corresponds to a small bump there. So this moving of the slab, which I think Dr. Avnindra also referred to, is so critical in picking up pathology. And this is another gentleman with multiple areas of macular edema, as the flow map shows. And also there's a non-perfusion. And you see here a very small area right up there of neovascularization, which you missed completely in the previous flow map, which was superficial retina. So moving it to the vitreoretinal interface really helps in picking up these early tufts of neovascularization in PDR. So yeah, just went past. So high magnification SSOCTA helps look at IRMA evolving into neovascularization. So in baseline, you see here, there's some flow density increase at baseline, and that is slowly increasing. At 1 month, you see it's just reaching up to the surface, and at 3 months, you see it's breaking through and forming that neovascularization. It's also great for looking at evolution of NV, as I mentioned earlier. It's captured on OCTA. You see a little bit of neovascular tuft there. On the flow map, you see there's a little hyper vascularity there. In magnification, you see it's still below the ILM. So it's still IRMA. And in time, in 1 week, you see it slowly coming up and pushing up that ILM, and you're seeing the early birth of a neovascular complex. Now, after 1 month, you see it pushing up further, coming up above that level, and at 3 months, you see it bursting through, and now it's a full-blown NVE. So this is great documentation of IRMA going on to becoming a NVE. And so Russell et al. Showed that IRMAs can directly evolve into neovascularization. This evidence was first given by swept source OCTA, and it mandates early detection, helps early detection and frequent monitoring of the IRMAs, as well as early detection of neovascularization and diagnosis of PDR. So using the same field of view, wide field SS OCTA gives you as much as ultra wide field fluorescein angiography. All IRMAs, NV, and areas of retinal non-perfusion identified. Changes on ultra wide field fluorescein angiography also seen with wide field SS OCTA. Wide field SS OCTA is all that's needed to diagnose and manage every stage of diabetic retinopathy. So DR stages increased, in conclusion, increased phase dysmorphopsia, DMI, correlates with progression in stages of diabetic retinopathy. The grades, increased DME severity, phase area, foveal thickness corresponds to worsening of visual acuity, so functional correlation there. DME and anti-VEGF response, poor responders, remember the significant damage to DCP, not really superficial capillary plexus. It's a marker for poor response, deep capillary plexus loss, and corresponding OPL disruption. Diabetic macular ischemia, degree of diabetic macular ischemia can reliably be assessed by OCTA SCP changes. In OCTA DMI assessment, there is substantial intergrader agreement, which is better than what you will get with FFA. Peripheral capillary non-perfusions, OCTA phase dysmorphopsia, and DMI correspond to increasing peripheral capillary non-perfusion. And wild field SS OCT imaging has the potential to replace color fundus imaging and FFA as the gold standard for routine assessment. As I say, routine assessment, routine non-invasive assessment of disease severity, staging, and deciding when to treat. Future perspectives may be that OCTA may be promising non-invasive tool in daily DR screening, and the advent of AI and machine learning coupled with DR OCTA big data may herald a new age of preclinical diabetic retinopathy screening, clinical DR staging prognostication based on OCTA markers. Thank you.
Thank you, Dr. Anand, for a very nice presentation. Two things again, what Anand has mentioned is segmentation is one of the important things. Small lesions, if you have a suspicion, you should sit on the machine and look at this lesion to diagnose this lesion. I'll request any questions from the audience to Dr. Anand. Meanwhile, I'll request Dr. Ajay to give his talk on retinal vascular diseases, and he'll also touch about the optic nerve head findings in OCTA.
Dr. Anand, there is one question for you. How do you work with OCTA in a lasered diabetic retinopathy? How much is your reliability when you're looking at lasered retina? Because all the lasered area also appears quite no flow area of avascular, and neovascularization sometimes becomes difficult to kind of say whether it's active or so. Do you rely on OCTA and lasered DR that much, or is it more like an initial?
Yeah, I think that's a very good question, and the answer is almost in the question itself. Because when you laser, you're destroying a lot of area, and photocoagulation, as we know, is a through and through tissue damage. So the entire vasculature is going to be really corrupted out there. So in fact, sometimes it's not that easy to even get those images in an intensively lasered area. So the whole area is distorted, and especially a lot of these cases will also have fibrous tissue around. So that further obfuscates the thing. So to a short answer to your question, I don't really rely on OCTA for picking that out. But yes, it's I mean, if it's in the posterior pole and it's a non-invasive thing, get an OCTA, see if you do see a membrane, and if you have had the benefit of having done an OCTA earlier and you see some changes, then fine. But I would rather go by clinical judgment more than
Initially, Ritesh, I was very perturbed not seeing laser marks in a laser dye. Then what I did, I went to a choroidal slab. Once you go to a choroidal slab, you will see laser marks, and that is one thing what you can do. I'll request Dr. Ajay to.
Good afternoon, everyone. I would like to thank AVNINDRA sir for giving me this opportunity. I will be discussing retinal vascular disorders. Diabetic retinopathy has already been discussed. I'll be touching upon mostly on BRVO, CRO, and few cases of PAM and optic nerve head. So these are the cases which we usually see in OPD, and mainly concentrating on BRVO because it's the second most common retinal vascular disorder after diabetic retinopathy. And we have an acute phase and a chronic phase. In acute phase, what we see are the hemorrhages, the soft exudates, hard exudates, tortuous veins, retinal edema, and distribution of S-shaped distribution of the retinal hemorrhage around the vein occlusion. The FA findings which we see here conventionally sees a delayed filling, but most of the time it's occluded because the obscured because of hemorrhages. And in chronic BRVO, what we see is the vascular abnormalities which develops along the distribution of the vein, and there are collateral formation, microaneurysms, and telangiectatic vessels which are there. On FA, there is capillary non-perfusion and the leakage of neovascularization. Now, what OCTA helps in BRVO cases, it clearly demarcates the territory involved and shows the presence of even the macular ischemia which is there. And neovascular patch, if there any, it can easily demonstrate and show you that's there. And even the depth of ischemia, the superficial or deep, the structural imager will show you. I'll show you some cases which clearly demarcates it. And even if you want to laser those sector for a BRVO, it will give you a complete, the montage will give you a area where you can actually laser. It's a complete non-invasive, and even you can follow up the patient's post-treatment on OCTAs. So this is a case, a first case which I'll show you. It's a superior BRVO, and you can see, can I have the pointers? So this is a superior temporal BR. You can see the multiple areas of capillary non-perfusion which are there, a big area here. And you see superiorly, these are the small neovascular patch which has been developing in these areas. So you can counsel the patient and ask the patient to undergo laser or anti-VEGF injections. So this is an interesting case which came up. That is a 74-year-old hypertensive male, and he came with a history of scotoma in the right eye. On examination, found out to have a small branch vein occlusion. And he said the left eye also has a diminished vision past 1 year. And what you saw was an old BR view which was there with a huge area of macular ischemia, and it was around 612 vision. And since there was no macular edema on the right eye, so there was no anti-VEGF injection which was given. But when the left eye was subjected to a montage, you see a huge area of non-perfused area which is there, and this patient was subjected to a PRP, a sectoral PRP laser. There's a third case with a elderly female which presented to us BRVO, the inferior temporal BR which is there. You see the multiple areas of non-perfusion which are there. And she was advised to undergo a sectoral PRP because more than 5 disc diameters of non-perfused area was there. And this is a case where we have a follow-up of 3 years on OCTA, and which demonstrates how the disease progresses. So this is a 60-year-old female who came with the history of this decreased vision in the left eye. Past 2 days, she was observing some black areas which were there. So on examination, we found out these are the collateral vessels which were there, and this is the whole inferior temporal area which was completely non-perfused. And if you see the structural OCT, we see inferior, there's a neovascular patch which is there. And if you see the structural OCT, there's also the deep vascular layer which is ischemic. If you compare the superior and the inferior, you can see the difference in the grading of color. It is more dark, which shows the extent of ischemia which is there in the deeper layers. So on doing a 8x8 scan, which you can see clearly the macular ischemia which is there, extent of macular ischemia, and the collateral vessels which has developed there. So the patient was subjected to multiple anti-VEGF injections and multiple sittings of sectoral laser, and this is how the patient presents after 2 years. So you can see, if you see a small area of neovascular patch, after 2 years it has advanced to a big neovascular patch, and which is very easily being documented here. Even these areas which are there, these are the areas of vitreous hemorrhage which presents as black areas, and some areas of newer neovascular patch which has developed in due course of 2 years. So the patient was again subjected to PRP augmentation and anti-VEGF injection. And you can see when the vitreous hemorrhage cleared, what we saw was these big patches, which were again, you see here, this was the previous, and after 1 year when the patient again presented to us was, these neovascular patches are completely increased, and these patches which were small before has increased. These patches has regressed, but you see these patches, they are increasing in size. So this is a way to document the disease progression, and you can also explain the patient how the disease is progressing. So the patient again was subjected to anti-VEGF and PRP lasers augmentation, and you can see after anti-VEGF and PRP how these neovascular patches they actually regress, and you can actually demonstrate. You see this big patch has gone down, this patch has gone down, and it's a very beautiful way and non-invasive way to document these changes. And in 3 years, what we see, this was the presentation, the macular ischemia and the collateral vessels. And after 3 years, these areas are still there, but what we see is this line on structure. This is the formation of ERM which is being taking place in this patient, and you see this dragging of macula is there. Still, some of the patient is maintaining a 612 vision, and she doesn't have any major visual complaints. And an entity which I'm going to cover is PAM, which is a paracentral acute middle maculopathy. It is a diagnosis which has been proposed on SD-OCT. So on SD, there is a retinal capillary non-perfusion ischemia which is there, and it could be a precursor to maybe a CREO or a CRVO which is there. What we see is the hyperreflective bands on OCT, which are seen in the internuclear layer, and the outer retinal layer is completely spread. So this is a 54-year-old hypertensive male which presented to us. This stereoscotoma which was there, and what we saw on the outer retinal layers are completely spread, but we see the inner layer, they are patchy, or the hyperreflective bands which are there in the inner nuclear layer, but the outer layer is comparatively near about normal. What we saw on the ONFAS OCTA was, you see the larger vessels, they're completely fine, but what we saw at the capillary, the small capillaries, these are whitish patch which are present over the posterior pole, and these are the capillary non-perfused areas which are the feature of PAM. So this patient was diagnosed as PAM, and he was kept under observation. Luckily, these regions resolved, and there was no other complication which developed. And what we saw, because we know the PAM is a disease of outer inner layer, so the superficial layers were completely normal, but what we saw was the deeper layer which completely non-perfused, no clear demarcation of inner retinal vasculature is seen here. In case of CRU, when the patient usually presents to us, it's the macular edema which is there, the central edema, and which is the cherry spot is there. So even if you scan the central area, the vessels won't be clearly visible. So what we do, so this is a case I will show you. A 69-year-old male presented with decreased vision in the left eye since one day. He was already given ocular massage and a AC tap before when he presented to us. And what we saw was the CRO in the left eye, which is there. You can see the typical presentation of CRO and OCT. And when we did an OCT angio of the optic nerve head, the optic nerve in the right head, you can see the vessels are there, the capillaries are there, the clearly perfused. But what we see, the left eye, the disc, and the small vessels, they are completely obliterated, or they are not actually very well seen on day of presentation to us. And 7 days after presenting to us, the patient developed a myocardial infarction, and he went angioplasty. So after 1 month, when he presented, he came back to us, the edema has gone down, but visual acuity has improved to half-meter finger counting. And we all know that after CRO, within a week or more, there's a recanalization of the vessels. The perfusion starts after a week. So how to document that perfusion? So what we did an ONH angio again. So this was on presentation, if you see these vessels, and this was after 1 month of CRO presentation. You can see these capillaries, these are now visible, and their perfusion is slightly better. Maybe not normal, but slightly better than what was there on the day of presentation. And we can document these small capillaries which are now visible. But again, the right eye was completely normal on that. So one small... Okay. Yeah. So concluding, the OCTA, even in vascular disorders, is really good tool, especially in documenting the progression of the disease. And you can actually tell the patient how the disease is progressing, and it might need repeated treatment, the lasers on the injection, and you need to counsel the patient as per those indications. Thank you.
Thank you, Dr. Ajay. And I'll request Dr. Rajesh Shashikumar will be shifting from retina to glaucoma, and he'll be giving his talk on OCT. एक थोड़ा सा 5 मिनट. हाँ.
Thank you.
Okay. GBM यहाँ पे होना.
Right. So good to start. Okay. Sure. Sure. We just wait or we start?
No, you can start. पता नहीं मेरे को लगा कि रीवा में होना है.
बता देना जब 4 हो जाए तो. जब 4 है तो बता देना. So good evening, friends. This general body meeting is adjourned and we'll reconvene at 4:30 p.m. because of lack of quorum.
Okay. So after having listened to a whole hour of talks about OCT angiography with regard to retinal diseases, we will now sort of look at how it can help in diagnosing and managing glaucoma. Now, the big question has always been, yes, there is intraocular pressure and intraocular spikes. That's one point. The other point is the vascular insufficiency that develops from the raised pressure. But the question is reduced ocular perfusion primary to primary condition or a secondary condition to RGC death? So RNFL thickness, GCC thickness, RGC function, and visual sensitivity and electrophysiology and other metrics are RGC depth related biomarkers, while ocular perfusion is analyzed using the FA, Doppler flowmetry, speckle flowmetry, Doppler OCT, or MRI. Now, there are limitations with all these methods. Now, OCTA, I'm not going to go into the mechanics of it or the principles behind it. That's been explained very well by the previous speakers. But if you look at it from the glaucoma perspective, we are looking at comparison between normal and pre-perimetric optic nerve images, besides finding areas of capillary dropout as shown by these images. And in this sequence of images, you can actually see the difference between mild, moderate, and severe glaucoma over time and comparison with OCT images and field images progressively. So peripapillary angiography is something that actually shows the difference over time with the box plot images. So normal and glaucomatous eyes have a drop in the number of peripapillary flow density over time. Patient with normal images, you can actually see the fact that there is no capillary non-perfusion. You can see the patient with the wedge defect that shows up as inferior nasal step, and on the peripapillary pictures in the multicolored multimodal pictures, you actually see the capillary dropout. Now, advanced glaucoma, of course, this is very challenging because there's such extensive capillary dropout. It's very difficult to say how we quantify this. So over time, how this can actually change, we can also look at inside the disc vessels or also at the level of the macula. And then the OCT regions, OCT actually scans superficial, intermediate, and deep. Fractal analysis is a quantitative method of evaluating the vessel density over time. And this actually allows us to get much more information about spacing between the large vessels, spacing between the small vessels, optic disc, small vessels, and the large vessels as well. It actually generates a contour heat map across the various vascular metrics. And you can also then superimpose or overlay over the optic nerve head with the various regions of the visual field mapping and also the GCC and the RNFL maps as well. And it actually shows quite good correlation across structure, function, and vascularity. Current literature in OCTA and glaucoma, about 100 plus peer-reviewed articles. So what should we be looking for? How good is OCTA as a tool to pick up or evaluate glaucoma? How repeatable or reproducible is it? What's the correlation of the parametrics with established metrics like nerve fiber layer thickness and visual fields? How does it perform across the different types of glaucoma spectrum, and what are the subtypes? So significantly low OCTA parametrics in glaucoma eyes is been seen in comparison with normal eyes. And the diagnostic ability increases with increasing severity of glaucoma. Now that's tricky because we don't need OCTA to identify glaucoma when it's severe. We already know by looking at it clinically. Reproducibility and repeatability have been found to be pretty good. If you look at correlation of parameters with established metrics, significant correlation has been found with visual field mean deviation. Strong OCTA function association has been compared to OCT RNFL function association, and possibly vascular loss might have been a better biomarker than structural changes for the difference, for the decrease in visual function in eyes with glaucoma. In ocular hypertension, it has been found that because of the dysregulation of the blood flow in these eyes, you can actually identify reduced perfusion. Pre-perimetric glaucomas, this might be a good discriminant function to differentiate between pre-perimetric and established glaucoma. The data, of course, is limited in the macula and optic disc area for glaucoma, pre-perimetric and ocular hypertensives. Now, what happens when the disease is advanced? There's a floor effect like you have for OCTA, and that then makes it challenging because in OCTA, though, it seems to be that there's less impact on the floor effect because there is no limitation of the quantification as is there for the nerve fiber layer thickness with the standard OCT RNFL images. NTG showed significant correlation, and so did in-angle closure. However, the sensitivity is fairly better in open-angle glaucoma compared to angle closure glaucoma. So OCTA is non-invasive and objective. Repeatability is fairly good. It's faster and more objective compared to visual fields, and comparable discriminant function to OCT RNF function. Is it a better tool? Probably, with the floor effect not being a challenging factor, it might be a better tool than nerve fiber layer defects. There is, however, a lack of reference standards for evaluating the device because we don't have a normative database to compare it to. Longitudinal studies are required. It is restricted to specific groups of patients. Non-IOP related biomarkers need to be figured out, and we still don't know whether it's cause or effect. That's the answer to this. So it's good probably at this point to monitor progression in moderate and late stage monitoring. And small vessel acquisition is difficult because of the speed of visualization. The dynamic range is still a question. Correlation between structural and functional parameters need to be better established. The flow signal quantification is still a challenge. And if you look at it, do I need to incorporate OCTA in glaucoma practice at this point in time? Not yet, probably. But will I need to do it in the future? You need to rewind back to using the OCT in retina 30 years ago, and we all thought it would just be a fancy tool, and it's not. It's a game-changing tool. So that could happen. Thank you.
Thank you, sir. And with this, we conclude the session, and we thank all the speakers and the audience to be here. And